Now you'll see CKD is equivalent signs and symptoms wise to the oliguric phase of AKI. You mentioned last week, if I said that if the patient, instead of proceeding from oliguric to diuretic to recovery phase, if the patient suffers an additional insult or additional injury during the diuretic and the recovery phase, and then returns to the oliguric phase, there is no chance the patient is going to recover. They will permanently remain in the oliguric phase. So in CKD, this can either be a result of um, additional insult after AKI, or an untreated AKI or undertreated AKI, or this can also result from disease conditions such as diabetes, hypertension, and they're all listed here. Okay, so these are the risk factors for CKD. Right? So here are your risk factors. So let's examine briefly how would cardiovascular disease, diabetes, hypertension, and obesity lead to chronic kidney disease? What are they doing? Each disease condition does what to the organs? Mostly pre-renal, right? So, or it could also be, but the damage, is it acute or chronic? Okay, so this one says similar causes to AKI. However, the damage is over a long period of time. Unlike AKI, when it does it like this, right? So slowly, slow cardiac output, episodes over a period of months, over a period of years, or let's say long-standing unmanaged diabetes or poorly controlled diabetes or poorly controlled hypertension and obesity, which again, all of these resemble metabolic syndrome, correct? They can all lead to chronic kidney disease. There are stages in CKD. The end stage, obviously called ESKD, is also known as ESRD. ESRD means end-stage renal disease. However you want to call it, both conditions refer to the same, both terms refer to the same thing. The patient has no functional kidneys. The kidneys are there, they're alive, but they are not functioning, right? So they're still receiving oxygen, they're receiving nutrients, but they are no longer working. They are no longer cleaning the blood. They're no longer eliminating waste, no longer balancing fluid and electrolytes, no longer producing erythropoietin. So if these functions are absent, what happens to the patient? What will this patient look like? Can they eliminate medications?
No.
Can they regulate and make regulate fluids and make urine? Can they manage electrolyte levels? Can they therefore manage blood pressure? Can they also help produce red blood cells by, because erythropoietin is no longer secreted, right? So those are the resulting problems in CKD patients or in ESKD or ESRD, depending on which stage the patient is already at. So here are your problems in patients with CKD now. Table 48-1, this enumerates not only the problems, but the management strategies. And second column tells you the manifestations or signs and symptoms. We don't need to review this. We already did this on week 1. Okay, so this is dehydration and fluid volume excess. And same thing for sodium and potassium imbalances. And this morning, we touched on hypocalcemia, correct? For what is that transfusion reaction again? massive blood transfusion reaction, or also called multiple blood transfusion reaction. The problem in the accumulation of waste products is the patient goes into an acidotic state. Metabolic acidosis is the result of accumulation of waste products, and this can be especially harmful to the patient's brain. Of course, you will see manifestations like why is there increased respiratory rate mentioned here is because this is Kussmaul's respirations, correct? You remember in fundamentals. So this is a compensatory response to the acidotic pH of the blood. And we have metabolic acid alkalosis, which is now the opposite. So if you have increased respirations in acidosis, now you have decreased respirations in metabolic alkalosis. The patient's albumin is low, magnesium is low, or they can also have hypermagnesemia. The problem with magnesium imbalances is this contributes to, especially hypomagnesemia, this contributes to further hypertension because with insufficient magnesium, one of the jobs of magnesium besides muscle contraction is it allows the arteries to relax. So therefore, if your magnesium levels are low, then what will happen to the arteries? They'll be constantly constricted. So therefore, they're narrowed all the time. What happens to blood pressure? Because what happens to afterload? Increases afterload. This is a big strain on insurance companies, particularly Medicare, Medicaid. People are living longer with dialysis, and this is very costly. Average dialysis session is thousands of dollars, and the patients need to do this 3 times a week for the rest of whatever remaining life they have. Because they have no kidneys, so the dialysis will have to replace the function of those kidneys, and they depend on these treatments in order to survive. These are again the top 2. So likely if you work in dialysis, when you go into that dialysis center, that dialysis room, half of your patients will be diabetic. And of course, with diabetes, that always has hypertension with it, correct? They always go together. Again, they share the same risk factors. They all have metabolic syndrome. There are, of course, other causes that lead to ESKD, and they're mentioned here. We'll discuss the others on module 9, okay, under the other urinary disorders. As I said, there are many stages in CKD. I'm not testing you on the stages. Again, this is a doctor's concern, right? So we're not diagnosing, but just be aware that, of course, stage 5 is when the patient will require dialysis. Now, take note, last week when we talked about AKI, we did discuss dialysis briefly, correct?
No.
Because, no, I mean that AKI patients may require short-term dialysis. Yes, that is an option when the potassium levels are very high, that we cannot control it, meaning the patient's having frequent dysrhythmias because we cannot lower it fast enough, right? So in short term, the patients with AKI may undergo hemodialysis, but this is not permanent though. This is just short-term dialysis. Manifestations, let's keep it simple. What did we say this patient's fluid status is in? As referring to the phases of AKI? The oliguric, right? Okay, so therefore when they're oliguric, are they in fluid overload or fluid deficit? Fluid overload, because they are in, right? So the fluids that they're taking, is it going anywhere? They'll just stay in their body, resulting in fluid overload because they can they make 1500 ml of urine per day? No, they are now making less than 400 ml per day. So the table we just discussed earlier, those electrolyte imbalances there, in addition to the fluid overload manifestations here, namely the hypertension, or they can even have heart failure. The fluid overload gets so severe that their heart cannot take it and it fails. Here's GFR again. So in chronic kidney disease, unlike AKI, wherein we depended on the urine output for proper diagnosis and assessment, this one we will now base it on GFR. So you can see on the stages earlier on this table, chart 48-1, this is all based on what? GFR. Nothing mentions here about urine output anymore. Let's go now to management. So how did we manage fluid overload again? We gave diuretics. What else did we do? Fluid restriction. And in this case, those two, will those be enough? No, we will have to treat the individual problems. So starting with anemia, for instance, what do we do? How can we help the patient? They will have anemia because of the no erythropoietin. So we're going to give erythropoietin, okay, in the form of epoetin alpha. Is that enough though if they have acute anemia? No, we will require blood transfusions, which we just concluded today. So this is now the treatment. So it's going to be requiring a lot of management. Okay? So these patients will be one of those that have the longest list of medication orders. You look at this patient's MAR, it'll be pages. You'll scroll down probably 5-6 times. Okay. We'll discuss medication management shortly. So as mentioned in this paragraph, we have the only thing we can do is really, let's say the patient, doesn't mean the patient's already in ESKD that we just say to hell with it. Okay, because there's nothing, it can't get any worse. Actually, it can get more worse. So therefore, we can still conserve, we can preserve whatever kidney function is left, however low that GFR is. We don't want to exacerbate it, meaning, can we just say, oh, your kidneys are gone anyway? Go ahead, just drink alcohol and eat whatever you can. What else could get worse? Actually, yes, it can get worse. The patient will die. Okay, unless of course the patient just wants to give up. Yeah, go ahead. Okay, yeah, and then enjoy your life. But if they want to live, of course, they want to preserve what remaining kidney functions they have. So this will involve conservative management. Let's say, do they take medications, especially over the counter? Indiscriminately like before? No more. Okay, so with same thing with the doctors. So doctors will have to adjust all the medication doses based on the GFR. So here are the others. So we still control the underlying risk factors, the whatever led to the CKD, the diabetes, the hypertension, the anemia, stop smoking, okay, exercise, everything written here. It's hard to do that, especially with the elderly, because remember, if they're in, let's say, 69 to 80 years old, they're on dialysis. How many years have they developed that lifestyle that led to this? 69 to 80 years. So is it easy to change overnight? No, they need support, they need understanding. And don't just go, no, don't kick them while they're down, meaning don't say, oh, now you're complaining. This is what got you here in the first place. Okay, so stop making those comments. So just support them. Okay? You continue to encourage them, even if they're already old and likely to die. Okay, because they still deserve teaching and treatment and understanding. Of course, there's an option of kidney transplants, but the list is so long, so they're probably at the bottom if they're even on the list. So the kidney transplant list is so long, and there are complications related to kidney transplantation or any organ transplantation for that matter. We'll discuss that next semester. So for this chapter, we will not cover kidney transplantation. So as I mentioned, the medication doses here will be carefully calculated by the physician so that we don't, because what will happen to drug levels if the kidneys aren't working? Okay, it will stay, right, it'll lead to toxicity. It's not just for certain medications, it will be all medications, okay? So that's one thing you should consider. Even if they're not in CKD, if they're in AKI, this do the same thing. In the elderly specifically, their kidney function is already decreased to begin with, right? Even without CKD or ASKD. So keep this in mind whenever you give medications, especially sedatives. Okay. So let's face it. Do any of you want to take care of a confused, delirious patient for an entire 12 hours? No. So what do you tend to do? All right, exactly, right? So you want to right. So when you do get those orders, be careful about the dosing. Don't be impatient. So let's say you gave the dose and then 4 hours later, still no effect. Then you're tempted and you have the order, then you go ahead, okay, I'll give the maximum dose. Then you will also suffer because that's still your patient. Your shift's not over. This patient goes into toxicity, overdose. Whose problem is it? Still your problem. Okay, so always consider that. Let's go now to ESKD and renal replacement therapy, sorry. So this is now the dialysis. So the patient, unless again they receive an organ transplant, will have to will require renal replacement therapy for life. There are choices, and then the patient will have to, together with their physician, decide on what will be the best type of dialysis for me. We already discussed the pathophysiology and the manifestations. Let's go now to the therapy. Okay, so these are the problems, and then our goals, of course, is to control them. So there is sodium and water retention in these patients. Obviously, there are no kidneys. So they will have hypertension, they will have symptoms of fluid overload, or even heart failure. The acidosis, the treatment here, the patient will have to be in between, especially in between dialysis days. They will be placed on sodium bicarbonate. So obviously, what will sodium bicarbonate do? It's a base, right? So it will neutralize the metabolic acidosis. Then the anemia treatment here is what again? Epoetin alpha. Okay, so there is no more erythropoietin. So they will require lifelong epoetin alpha injections. So this comes in a vial. So this will be given subcutaneously once a week for life. Because otherwise they will require so many blood transfusions, which is costly, right? And eventually you'll have complications related to transfusion reactions because your risk of a transfusion reaction increases with every subsequent blood transfusion. So the more blood transfusions you receive, the higher the chance that you will have a blood transfusion reaction. So we have blood disorders because of the calcium imbalances. So you'll have both vitamin D and calcium and phosphorus problems. So here are your problems system by system. Now the asterexis here is basically brain damage due to the what we call uremia. The patient has so much BUN creatinine in the bloodstream that it damages the brain. You'll see asterexis also in liver failure patients because the liver also gets rid of ammonia. So both conditions, ESKD and liver cirrhosis, will both cause neurologic impairments. So we've got, together with this again, so these are damage to the brain. So the patient will have changes in their behavior, mental status, they'll have neuropathy, disorientation, and can these lead to injury? Yes, especially seizures. Yes. Sorry? I'll bring it during the break. Okay, the skin, these are the changes. The patient also has this dry, flaky skin, and some white powder will appear on the skin. It will taste salty. Okay, so all you need really is just lime, and then you can do body shots on these patients. And they'll make very good dedicated drivers as well. So cardiovascular, obviously, heart failure, fluid overload. We'll discuss the other terms, pericardial tamponade and pericarditis on module 8. Pulmonary, related again to fluid overload and heart failure. GI, you have this bad breath. This is basically the waste products in the GI tract. And anemia, as already mentioned. Reproductive, of course, who has the libido here when this is how you live every day? No more, right? And musculoskeletal, as I mentioned, due to calcium and phosphorus and magnesium imbalances, they'll have fractures. Let's go to complications now. We already mentioned most of these in the previous paragraphs and charts. So let's summarize again. So there will be anemia, bone dysfunction, hyperkalemia. Among these, the most life-threatening is which one? It will be the hyperkalemia. So this is usually the reason why a patient will be admitted to the hospital. So they'll have usual complaints is the patient passed out. Okay? They collapsed. They had syncope because they're in dysrhythmia already. So they had a serious dysrhythmia, decreased cardiac output, they passed out. So here's the management now. So in addition to individual management, namely anemia, hypertension, so there's medications for each of those, right? So the acidosis. Then of course, the main therapy would have to be renal replacement therapy. So here are your medications again. I won't go through each one. We've already mentioned most of those. Samuel asked me earlier if instead of giving blood transfusion, why not just use erythropoietin? So here's the answer. That's why we give erythropoietin or apoietin alpha weekly, is because it takes a long time for it to correct the anemia. So if their blood count is really severely low, let's say under 7, can this alone treat that? No, they will have to require a blood transfusion. Plus, during hemodialysis, while their blood is outside the body, the patients actually lose even more blood. Not a lot, but that contributes to more anemia as well because of the 3 times weekly hemodialysis sessions. Nutrition. So the patient's BUN creatinine is high. Where did BUN creatinine come from again? BUN specifically? From protein metabolism. So therefore, what do we do with their protein intake? It'll have to be restricted. So here's the restriction. We don't need to memorize this because are we the ones prescribing the restriction? No. Now, some doctors will not be too stringent about the protein intake, especially if they're on dialysis, because during dialysis, whether hemo or especially if it's peritoneal dialysis, they actually lose protein. So in peritoneal dialysis, the patients have no protein restriction at all. In fact, they're be given additional protein, okay, in the case of peritoneal dialysis. But in hemodialysis, again, especially on dialysis days, they typically are not very strict with the protein intake because they lose some during dialysis. I'd like to emphasize again the importance of intake and output measurement and recording, because the fluid restriction is always based on what 2 things again? How does the doctor decide on how much fluid restriction to place the patient on? It's always look at this statement here. The 24-hour urinary volume, meaning how much did they pee yesterday, plus the insensible fluid loss. Remember, we have insensible fluid loss. So that's how the doctors estimate how much fluid the patient gets. So therefore, if you missed 2 or 3 urinary output recordings, is the fluid restriction going to be accurate? So what are you doing to the patient? You're dehydrating the patient, right? Because of course the doctor will, oh no, sorry. If you recorded less, that means the doctor thinks the patient only peed, let's say 100 instead of, let's say 400. So what happens to the patient? You are dehydrating the patient, right? Giving them less fluid intake. And whose fault was that? Okay, yours, because you did not accurately measure the urinary output. All the other nutrients, of course, will have to be restricted. Each electrolyte will be restricted for obvious reasons. So the dietitian here and the physician will, of course, collaborate, and then you are the ones implementing it. So here's dialysis now. So this is the method. It's a procedure where we try to replicate the functions of the kidneys, particularly with fluid and electrolyte and waste product elimination, okay, using either a machine or the patient's peritoneum. Let's discuss each one. The individual nursing diagnoses here are referring to increased potassium, increased fluid volume, etc. They're all in the nursing care plan. I'll skip that part. I'll leave that for you. Let's go now to your responsibilities. Okay. So education is very important. The patient needs to understand that is dialysis a cure? This is simply going to prolong their life. So this is going to be done frequently, depending on how the frequency, depending on what type of dialysis the patient and the doctor chose. And as usual, we of course want to, sorry, I skipped this part. So these are reportable manifestations. So what are these manifestations of? Let's look at the first bullet. What is that? That's from acidosis, right? From uremia. What about the hyperkalemia? Okay, obviously. And then finally the, so this is for the, here the clotted fistula or graft. This is referring to the access, hemodialysis access. We'll discuss that shortly. Okay, what's happening is I'm recording on the laptop and it won't let me plug into two different devices without crapping out. All right, so here are the three methods of hemodialysis. The hemodialysis, and then we have CRRT and peritoneal dialysis. As far as CRRT, you will only see this in the ICU. What is CRRT? This is continuous renal replacement therapy, meaning the patient undergoes hemodialysis 23 hours a day, every single day. So this is only for critically ill patients, meaning unlike HD, hemodialysis, the patient's fluids and electrolytes, fluids specifically, are removed in large volumes. So the patient can have, let's say the dialysis lasts for 3 to 4 hours. The patient may get 3 to 4 liters of fluid removed there. That's a lot of fluid, correct? So this is only appropriate for stable patients, healthy patients. However, CRRT are critical care patients. So if these are patients in shock, in severe heart failure, can they tolerate 3 to 4 liter removal? No. In a matter of hours? No. So that's the only time you will see CRRT. Peritoneal dialysis is done at home. Although we do have home HD machines now, they're smaller, obviously. The patients can do them themselves. However, they can only remove up to 1 liter per day. So therefore, can they do it 3 times a week? No, they will have to do it every single day, right? So not too many patients are amenable to that, to using HD at home, because it's a hassle. They have to do it. It's not really easy. Plus there could be complications and they'll still end up in the ER anyway. So most people just decide or opt for a dialysis center. They let the professionals do it.
So in person, you'll just 1 liter every day?
No, they take more. However, the process is little bits at a time though, unlike hemodialysis. I'll explain later when we get to PD. Again, the decision as to what type of dialysis will have to be discussed between the patients and the family and the provider. Unless, of course, they get a kidney transplant. Okay, let's start with hemodialysis first. Okay, so this can be either long-term or short-term. If it's short-term, the access will be a central line, a dialysis catheter. So the equipment used here is a dialyzer. It's a big machine, size of a it's about the size of a washing machine. Okay, it's big. It's capable of removing large volumes of fluid and electrolytes. I won't discuss how it works. I'll just summarize it. So it's going to mimic how the kidneys do it. So the kidneys do it through the nephrons, correct? So blood is filtered through the nephrons via osmosis. They still the same. So if the kidneys see, oh, there's so much fluid, of course it will remove the fluid, right? Still through osmosis, because which one will be higher in concentration, the cells or the bloodstream? The cells, right? Because you have so much fluid, so therefore it will go. This time it won't go into the cells; it will go into the loops of Henle in the nephron, and then that's how urine is formed. And same thing for the electrolytes. Okay, so they will diffuse out. So the machine does it artificially. So they use dialysate, a fluid called dialysate. So that will act as the osmotic membrane. Okay, so to facilitate osmosis, they will use a dialysate. It's a hypertonic solution to artificially copy how the kidneys do it. So it'll take a long time though, and this will involve rapid fluid removal, ranging from 1/2 liter all the way to 4 liters per session. And this is the illustration. Now, the access, like I said, we mentioned the dialysis catheter. So that's basically a central line. Here, this is a fistula or a graft. So the doctor will surgically create a large vessel by using, when we say a graft, they will put a soft silicone tube and connect an artery and a vein. So the dialysis nurse will puncture the graft, okay, the silicone tube. In the case of a fistula, the doctor will surgically connect a vein and an artery. And over time, that time period could be weeks, months, or years until the blood vessel created by that connection becomes big enough for you to puncture. Okay, so if it's big enough now, it will withstand repeated punctures of large 14 gauge needles. Okay, 3 times a week for the rest of their lives. It's not one needle, by the way. It's 2 14 gauge needles. Okay, so 2 huge needles because we're removing fluids rapidly. So we need a really large vessel, a really large needle. 2 really large needles. So this is how it is. So arterial blood will remove the arterial needle, will remove the blood from the patient, goes into the dialyzer, it's cleaned, excess fluid is removed, excess electrolytes are removed, and then the rest, the clean blood, returns to the patient via the venous needle. Any question? As simple as that. We'll get to the complications shortly, because it's not that easy peasy. Dialyzers we won't discuss because we're not expected to become dialysis nurses.
Professor, we can come here to the back.
Can you come closer? I can't control that
I'm
though.
sorry, you said
Yes.
the graph. This one is used for short term.
No. Grafts, although grafts don't last as long as fistulas, because grafts are artificial tubes.
Yeah.
Unlike fistulas, wherein it's the patient's blood vessel. Now, who can answer why does the fistula grow big? Okay, because the artery usually has higher pressure, correct? And low pressure in the vein. If you connect both, what happens to the vein side of that fistula? It will enlarge because it's a weaker blood vessel. Okay, so when you expose a vein to the high pressures of the artery, that's what's going to happen. It's going to enlarge and dilate, creating a really big blood vessel, right? And you can't miss it. You stick that several times, you can't miss it. Vascular access, so this is the, again, for short-term purposes. Also, if your patient has, let's say, problems with the fistula, okay, got damaged, for instance, got clotted, we have no choice but to put in a vascular access. So what are the options again? You still remember the tunneled and the non-tunneled? So which one would be for long-term dialysis access? A tunneled dialysis catheter. What about for short-term? Non-tunnel. Short terms are preferred if the patient has, let's say, an active infection. Okay, so they have a active blood infection and they need dialysis. Which one would you use? A tunneled or a non-tunnel? A non-tunnel, because we're not leaving it in. Okay, we need to put it in, perform dialysis, take it out again. Okay, so the patient will have frequent insertion of that non-tunnel catheter.
Can they use a port catheter
So what?
for the dialysis?
Peripheral? You mean a port?
Port, yeah.
No, a port cannot be used. It's too small. Okay. Okay, so I won't repeat the tunnel, non-tunnel. It's already written. We already discussed it. So these are the access again. We illustrated this when we did the central line dressing changes last 2 weeks ago. So here's what the AV fistula will look like. Now, it will become big, correct? So the vessel created by this procedure, when you join an artery and a vein, will become big. So therefore, if blood passes through that, what will you feel over that blood vessel? Okay, that's what we call a thrill, which is basically a pulse, right? So have you ever felt a machine or the car engine when you touch it when it's running? So you will feel a vibration. We call it a thrill. And that's good. You should feel a thrill. If you don't feel a thrill, that's bad news. You should report that to the physician. There's no thrill. Because what does that mean? There's no thrill.
Obstruction.
No blood flow is going through, right? You can also listen to it. When you listen, you will hear a bruit. B-R-U-I-T. Bruit is like a whooshing sound produced by blood flowing through a really large blood vessel. Okay, so that's what we check every day. Palpate for a thrill and auscultate for a bruit.
Are we assessing that before starting the dialysis or?
Not just during dialysis, but every time you do your assessment. Okay, so you always, the patient has fistula on one or both arms, then you document whether or not there's a bruit and a thrill. Let's go to and here's the difference between the fistula and the graft. I already described both. So graft can be used immediately after insertion. I mean, there's no need to wait for the vessel to mature because this is an artificial tube again that you just connect into an artery and a vein, and then you stick that tube. Doesn't last as long, so this is only for short-term use, okay, temporary use. Here's a QSIN alert. Thank you for reading, Miss Zibi. Failure of the permanent dialysis.
Failure of the permanent dialysis access, fistula or graft, accounts for many hospital admissions of patients undergoing chronic HD. Thus, protection of the access is of high priority. Although the limb alert bracelets are ideal to identify the excess extremity. Posted signs are also a good safety alert. The sign should state no lab draws, IVs, or blood pressures on access arm.
Are we clear with this? Okay, so you post that. You can put as many signs as you want. Put one on the door, by the wall, on the patient's bed, anywhere you can possibly put it. Okay, there's no limit as to how many, no matter how ridiculous it looks. So complications will be related to the access and also the hypotension. And of course, if you subject this patient to invasive procedures, what will they eventually develop? An infection. Okay. So one of those complications will kill the patient, okay, eventually. If not, it's not always a quick death. Let's say, for example, the complications listed here are angina, stroke. So the patient can still live, can still survive, right, after a heart attack and a stroke. However, what kind of life is that now?
Visible.
Okay, so changes the quality of life, obviously. So here are other complications. Frequently, it's hypotension. Because imagine removing 3 to 4 liters of fluid. What will that do to preload? Okay, so therefore, if the patient is getting dialysis today, what will you do with all their medications? Because these patients will have 2 or more hypertensive drugs. So is it a good idea to give them? No, knowing that they will have hypotension after the procedure. As far as whether or not you should give it after dialysis, well, check the patient's blood pressure, assess the patient. So when they return, do they still need those medications? To keep it simple, all drugs that are absorbed in the bloodstream are dialyzable. What does that mean? It can be removed by dialysis. So therefore, if you give it, is it going to stay in the patient's bloodstream? Pointless. So you're better off holding them. Okay. Exceptions are, of course, the topicals, okay, patches or eye drops, for instance. So those are okay because they're not, very little of it is absorbed systemically. So here are your complications with patients undergoing HD treatments. Now take note, the patients only go for dialysis typically 3 times a week. So what will happen in the meantime, in between dialysis treatments? So let's say they go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So what will happen in the Monday, Wednesday, Friday people? What happens to their Sunday, Saturday, and Sunday? Or even their Tuesday and Thursday? What's happening in the body? Waste products and fluids, anything excess are building up. So in between, they may have acute episodes, meaning they will have to be hospitalized, especially if they don't comply with the diet. No, they're on dialysis and they continue to have bags of Cheetos and Doritos, right? So that will get them hospitalized. Painful muscle cramping. This is due to the electrolyte imbalances that happen during dialysis and may continue after dialysis. Bleeding and clotting can also happen. Air embolism, although these are rare. Chest pain if they have atherosclerosis, or this dialysis disequilibrium syndrome because of rapid fluid removal. Rapid, large fluid removal. So the patient will have some syncope, they'll feel dizzy. And one thing not mentioned here in the case of a fistula is they'll suffer what's called steal syndrome. You know, just like the stop the steal. So steal syndrome is caused by, remember, the artery and the vein that was joined created a fistula, correct? So could some of the blood that passes through the arterial side go directly into the venous side? Yes, because they're connected. So if that happens, then what happens to the distal arm. It will suffer ischemia, and then the patient will have pain there, pallor, and then just extreme pain on the distal extremity. We call that Steele syndrome.
What do we do?
Nothing. Elevate the no, not elevate, because that will worsen it. We put it down and then just apply, a warm compress, something like that. Symptomatic, because there's nothing really anything else you can do. I mean, that's what's gonna happen if you create a fistula.
Does their glucose get affected also?
No, it's more because of their existing dialysis. I mean, it's a stressful situation.
Hyperglycemic at the next session.
No, because the dialysis won't remove blood sugar.
It's not the good,
No.
For the glucose.
but glucose is not-
Some patients will require albumin infusions. Albumin is another blood product. It comes in glass vial, 100 ml glass vial. It looks like plasma. So we already discussed the medications. So we only give medications if the patient requires those medications. Okay, so let's say you're gonna go to dialysis today, but then the sugar is really high. So do you give insulin? Yeah, you have to. Okay, it's too high. Let's say over 150, over 180. Then of course you have to treat it. Or the blood pressure is really high, over 200. Do you wait for dialysis? No. Okay, we already discussed fluids and nutrition. And dietary restriction. For meeting psychosocial needs, it's really the same from chapter to chapter. I mean, what do all of these sick patients develop psychosocially? Depression, self-esteem, right? Problems. Because let's say this is a teenager. They have that really ugly, large fistula. Is it cool? Is it attractive? Is it sexy? No. Okay, let's go now to the teaching. Chart 48-10. I'll just point out a few important items on it. So for what to report. So make sure they know that they should weigh themselves every day, same clothing, same time, same scale, right? You do the same in the hospital. How to protect the vascular access. It was mentioned earlier that can you use that for blood pressure?
No.
Okay, so blood draws, nothing like that, right? Can they also play sports with that arm? Okay, they should not. So emphasize the importance of protecting that vascular access limb. For obvious reasons, they depend on their survival for that dialysis access. Yes.
So regarding the sports question, would they be able to, if they were to go to the gym and weight train, since they weren't interacting with another athlete, would that be safer?
We generally don't encourage that because again, the vascular access could be affected.
So then maybe the only exercise they should do is just like cardio.
Isometrics, yeah, cardio, like that. Right. So plus I've never seen really hemodialysis patients have the energy to even go to the gym.
but probably.
Well, they do. So I mentioned home hemodialysis earlier, but again, this is not very popular because although insurance covers this, it's convenient, but again, not too many people like it because they have, it's a hassle. No, it takes a long time to do at home. Plus, they have to do it every day. Whereas hemodialysis, they only do 3 times a week. We actually have a CNA, the hospital where I work, and he's on dialysis. He works as a CNA. So of course the manager works with his schedule to accommodate his dialysis sessions. Sometimes he gets readmitted for the same reasons as the textbook mentions. Okay, so he parties. I mean, he's alive. He still smokes. He's a diabetic, and yeah, he gets he gets readmitted. Okay, and he's not the best patient either. Just thankful I've never had him for a patient. So CRRT, long story short, I won't test this. I already described. So this is reserved for really critical patients, okay, hemodynamically unstable. Plus, you'll never perform this anyway. So this is only in the ICU. Now, the RNs aren't doing it. Okay, so we still have a dialysis nurse that sets it up, but they won't stay there for the whole 23 hours. You just call them if there's any problem. Let's go to peritoneal dialysis now. So this is done at home. It's an option for patients who like to travel. Yes, you can travel with hemodialysis. However, it's a hassle because when you travel, you have to make sure wherever you're going that there's a hemodialysis center. And you can't just walk in. Hey, the hemodialysis center, can I get hemodialysis? No, your physician, your nephrologist has to arrange it over time. I mean, ahead of time. So you have to plan ahead. Oh, I'm going to Costa Rica for 2 months. Okay, so we'll contact a center there. So your physician will coordinate with the nephrologist there and then send your records. Okay, are you going to accept this patient? Okay, we'll take him. All right, you're all set. You can go on your trip. Okay, so that's how it goes. Peritoneal dialysis, you can do this on your own at home. So this is going to use your peritoneal membrane. You know what the peritoneum is, right?
Yeah.
The sac surrounding your abdominal organs. No, the scrotum in your abdomen. Okay, so that's what we'll use. In order to make this work, I'll show you the illustration. We'll come back to this chart. I'll show you the illustration for the procedure right here. Figure 48-7. So what you're looking at is the patient's peritoneum. So this is inside the abdominal cavity. You have your abdominal organs there, your bowels, and then the doctor inserts a catheter. It's a short procedure, so less than an hour, you got it in, and it stays there. There's a portion of the catheter that will be sticking out near your belly button, and you'll put a dressing to keep it in place to stabilize it. And then you go home. So what you'll do is, what they'll do is send you bags of dialysate, similar to the dialysate used for hemodialysis, but these are 2 or 3 liter bags, huge bags. So what you'll do is wash your hands and then you'll hang this on a pole, the bag on a pole, and prime it just like you primed the tubing earlier for lab. And then you're going to clean the catheter, attach the tubing to the catheter, and then open the clamp. So the fluid, the dialysate fluid, will enter your peritoneal fluid. So that there are 3 phases here. So what I'm describing is called the inflow. Okay, so that's the inflow period, takes about 10 minutes. And then once the bag is empty, you close the clamp, disconnect. Next comes the dwell time. The dwell time takes about 2 hours. So for 2 hours, you will walk around the house or wherever you want to go. Want to go do shopping, go to the bank, do your errands, go to school, whatever you want to do. So that's for 2 hours. After that, you're gonna connect another bag, this time to drain the fluid. Okay, so do the same thing, wash your hands, wipe the catheter clean, attach a tubing, then drain the fluid out. While the fluid was in there, osmosis was occurring. So the dialysate is really a hypertonic solution. So it will therefore pull excess water, fluid, and waste products into the dialysate. And then what you're draining is going to look like urine. Right? So your dialysate fluid will be clear. What comes out will be urine. Waste, basically. So the outflow phase is about another 10 to 20 minutes. If in the event that you get less fluid out than you put in, because you're supposed to get more or less fluid than you put in. It's supposed to be more because you're eliminating fluids and waste, right? So therefore, you put 2 liters in. How much should you expect out? At least 2 liters or more. Should be more. Let's say 2,500, 2,200, as long as it's more. Okay, never less. In the event that you get less, all you need to do is tell the patient, okay, so just move around. Okay, so maybe lay down and then roll around. What's happening is some of the fluid is just caught in between the bowels. There are pockets there where the fluid accumulated. So that's all we can do. Just move around. Okay, press on your belly. Try to promote drainage of the fluid. So that should work. And after that, they do it again. How many times do they do it? Up to 6 times a day. So that's 3 hours, 2.5 hours each section, right? Let's say 3 hours, and you do it consistently. No, that was one exchange. So the 3 phases I just described, the inflow 10 minutes, dwell time 2 hours, outflow 10 to 20 minutes. That's about 3 hours, right? Total. That's what we call an exchange. Patients required to do 5 to 6 exchanges per day. Every day, forever. No, they can sleep. The last exchange will be during sleep. So they'll put it in when they bedtime, then drain it in the morning.
Sounds fair.
I mean, it works. Let's say I go to Disney World, right? This will work. I'll do inflow, plus I have a medical bandage, I have a health condition. So do I get a fast pass? Yes, no lines for me. So I'll do inflow, I'll do in the bathroom, show them my fast pass. This is my dwell time. Oh, run on the ride. Wow. Yeah, have fun. And then, okay, time for my outflow. Okay, I go to the bathroom, drain it. Okay, and then put another one. Okay, next exchange. Okay, and then more rides. Yeah, or go to the restaurant. Okay, it'll work.
So you can eat during your food.
Of course, the you'll have to adjust the amount of food because your belly is, I mean, it's not your stomach, just your abdomen is, the cavity is so large. Okay, so problems with this will be related to, you get back pains because you're carrying around 2-3 liters of fluid around. Okay, so it's, it's going to be heavy, so you'll have some back pains.
Body, even though this is where it was put in, it's blood from your
Yes,
whole
it's
body.
gonna, osmosis will do its job. Okay, so
Okay.
it will pull water out. Yes.
Can this possibly cause like nutritional deficit for a person because they're eating?
We'll get to the complications. Okay, so we discussed complications for hemodialysis. Now we'll have complications for this too.
When you said they would put over the night, isn't you have to wait for 2 hours?
No,
Over
it's
the night,
okay
you
for
have-
the last exchange. The last exchange, they can do it in their sleep, and then just drain it when they wake
So
up.
the bag is pumped, when it's drained, it's just like.
Yeah, it's only 10 minutes anyway.
And then, so when for the inflow,
Yeah, 10 minutes for inflow.
no, not the first one, the dwell time.
Dwell time, it stays there 2
So
hours.
just leave the bag.
Yeah, just walk around or lay down, whatever you
How
want to
you
do.
work in this out?
No,
Oh,
the
it's a
pole, you put it in for 10 minutes only. You hang it on the pole, 10
inflow.
minutes,
10
disconnect it, then you're free to
How you
go
work in
around.
2 hours and then you.
So in the 10 minutes that you hang it, that's when all of the stuff from the bag.
Yeah, the dialysate will enter
Oh.
your
What about
abdominal
those
cavity.
minutes you lay down or something?
Yeah, you can lay
The
down,
bed's
you can
lower.
stand, however, yeah, same like a Foley. Okay, so you connect it, you drain it. All right, so let's go back. We skipped over the advantages. So how would some of you grimace, right? Like, yeah, I don't like it. Okay, so these are the remember this chart 4811. So here are advantages, disadvantages of this. So you know what HD is. You know, you sit at a dialysis center, you can't travel without advanced preparation. You get those complications we mentioned earlier. So here's now peritoneal dialysis. Here's the advantages. You're mobile. You can travel anywhere you want. Because do you need a dialysis center for this?
No.
You're doing this yourself. You do need to carry lots of dialysates, okay? So cartons of it, because you need this several times a day. So there'll be stacks of boxes in your house with this because you require them every day. And then again, there's more liberal diet here. There's no restriction typically, of course, unless you're diabetic also, right? So no protein restriction because you're losing protein actually when you do it. So they even encourage, okay, eat more protein. Yeah, eat bacon, eggs. This is the disadvantages. You have to do it every single day, 24/7. Well, technically, when we say 24, you're sleeping with the last one anyway, okay? And here are the indications. Patients able to do it themselves, or there's a family member that can do it for them. Contraindications will be, let's say they have bowel problems. Okay, so there's an ischemia problem or some inflammatory bowel disease, so they can't do that. They can't have it. Or severe arthritis, because can they carry 2 to 3 liters in their abdomen? And if, let's say, you have back problems, no. Oh, or let's say you're obese. The stomach's already up here when you're obese, and then you add 2 to 3 more liters. Okay, so that's another contraindication. Or pregnancy. So I already described the procedure. We can skip through that. Important here is the aseptic technique. A patient must understand because we'll get to the complications and it can be deadly. A patient can have peritonitis. Right here, complications. 1587. All right, so there are acute and chronic complications here. Most acute is peritonitis. This can lead to sepsis. So this is infection of the peritoneum. So this can cause a lot of pain, require hospitalization, tons of IV antibiotics, and hopefully you survive, and then you never want to have it again. Leakage. So the catheter can leak. You've seen feeding tubes leak, right? Like tubes. Okay, same thing here. The catheter can leak. Bleeding. A little bit of bleeding is okay because, of course, the catheter moves around and rubs against your bowels, right? So a little pink is okay. But frank bleeding, meaning bright red or dark bleeding, is never normal. Are we clear? So that should be reported. So here, so first, bleeding is common during first few exchanges, especially if it's a new catheter. But over time, it should disappear. Or occasionally, pink, pink color, that's okay. As long as it's not really large amounts of bleeding. Long term, as I described, because of the weight of that, so the patient will have back problems. So here you can develop hernias as well, okay, with the diaphragm pushing up against the, no, your abdominal cavity pushing up against the diaphragm. So you can develop hernias there, difficulty breathing, and low back pain, as already mentioned. There's also different methods to do hemodialysis. What I described was continuous ambulatory peritoneal dialysis. That's the most common. For working professionals, they can still I already described this earlier, right? So they do side to side if, let's say, you don't get enough out. For active professionals, so this is what I described earlier, continuous CAPD, continuous ambulatory peritoneal dialysis. Now there's a option to do it with CCPD. So this one uses a machine to do the exchanges for you. So you just connect the catheter to the tubing and then the dialysate to the machine, you know, like a pump, and the machine will do the exchanges for you. However, is this ambulatory? No, you're stuck to the machine. Okay, so you have to sit or lie down close to the machine. Hey, if you do this option.
Do they still 60?
Depends on the patient. Sometimes, let's say you're at work all day, so you can do this when you get home, and then just do it continuously all through when you're sleeping. Yeah, that's an option. So you can do 12, 12 hours, or maybe 10 hours of this. So nursing management, same thing. Psychosocial, like I said, chapter to chapter, it'll be the same. Here's our teaching now. So it depends. What is the patient having? CAPD or CCPD? This bullet is very important with supplies. They should never run out. Problems will come with force majeure. Let's say there's a hurricane. We're getting more of those, right? So you get really bad storms, flooding. So logistics will be a problem. Will UPS deliver your dialysate boxes? Can they? I mean, the roads are filled with downed power lines or trees. Okay, so that could be an issue, okay, with these. So make sure the patient has adequate supplies each time. They have weeks of it worth. Okay, so each time they get a delivery, just first in, first out, make sure they keep track of the expiration dates, right? Okay, let's go to the what to report. Again, high protein intake here because of peritoneal dialysis. There's really no restrictions. So they should know the signs and symptoms of those complications you mentioned earlier, the peritonitis, the back pain, of course. And then let's look at the color of the dialysate. This is for vascular access again. So let's just do it common sense. If the dialysate, the outflow, when you drain the abdomen, if it looks brown, what could that be? Brown.
Or a lot of
Bleeding.
What's the color of poop?
oh,
Brown. What could that be? Poop. So what happened? What did the catheter do? May have punctured and perforated the bowels. What if it looks bloody? Obviously bleeding. What if it looks cloudy? So just like a UTI, your urine's cloudy, that's a UTI, right? What if the dialysate is, I got nothing else, that's it. All right, we did discuss the bruit or thrill already earlier. Okay. IV therapy. Should dialysis patients receive IV fluids? Is that normal? So if you get an order, how should you react? You should question it first, okay? So before you call and then, throw a fit, consider first, why did the doctor order this? So look at the labs, okay, what's why in the world would the doctor order fluids on, because it happens sometimes, because they may have a diagnosis of acute on chronic kidney disease, okay, meaning they're having an acute kidney injury on top of the chronic, okay, because that's possible. If that's the case, yeah, okay, but then always be careful how much you're giving though. And then always examine your patient. Is the patient showing signs of fluid overload? Because it'll be easy to see, okay, when you're giving IV fluids, because it goes up, it develops really fast. So here's the reason. Okay, so they could go into pulmonary edema, and this is a sign of what type of heart failure? Left side or congestive heart failure. So here's uremia again, the mental status changes we have. This is now pretty much you have urine in your blood. What's in urine?
Waste.
Waste products. So you have waste in your bloodstream. Do you want urine circulating in your bloodstream? What will urine do in your brain? Okay, so again, this is accumulation of waste products, and the patient will require dialysis when they develop this, like right now. Fluid overload, that's easy. As I said, we'll discuss these complications under Module 8, because it's really a long discussion and there's no discussion in this chapter. We've done this repeatedly, controlling diet. Okay, pain. So remember there's skin itching, right? Remember that white powder? Yeah, we call it a uremic frost, okay? That's itchy, makes the skin dry, and then of course, what will the patient do? Of course, you're gonna scratch it. Okay? Have you ever had an itchy butt and then you just left it alone? No way. Okay, you're gonna find some place or some position, to hide it. No, and then you're scratching it, right? So you have to scratch it. It's itchy. You have to scratch it. We'll talk about how you do it another time. Okay, I could use some added ideas. Blood pressure management, you already know. Hypertension management. Preventing infection, these patients are high risk for everything, COVID, whatever, okay? Because these patients are in a facility most of the time, correct? For dialysis, 3 times a week, they're in a medical facility. So they're always exposed to organisms. Catheter site, if this is referring to the peritoneal dialysis, you should have a dressing over the catheter. If it's a hemodialysis catheter, you treat it the same way as a central line, when we did central line care already last week. If it's a peritoneal dialysis catheter, can they take tub baths? No, not a good idea. Okay, because that will increase infection, right? Can they take showers? Okay. So medications we already discussed earlier. So how do you decide whether or not to give medications? Okay, assess the patient. Okay, only if they absolutely need it. Otherwise, if they're going on hemodialysis, should you be giving any of them? Always just keep in mind, is this dialyzable? How do you know it's dialyzable? Simple as, is it gonna be absorbed in the bloodstream? The answer is yes, don't give it. That's it. Any question on hemodialysis? Okay, come back at 3:03.